So a lot of things were in a state of suspended animation as the Affordable Care Act made its way to the Supreme Court. And in their ruling in June, the Supreme Court considered 4 issues. One is whether they actually couldn't act on it at all because there's a provision in law called the Anti-Injunction Act, which says that you can't go to court about a law that includes a tax until someone's actually paid the tax. Secondly, and that the court, interestingly enough, even though they found that the individual mandate penalty, or as it was called when Governor Romney first proposed it, the personal responsibility provision, is a tax, but is a minimal enough tax that it's not barred, that challenging it is not barred by the Anti-Injunction Act. So in other words, they didn't punt. They actually went ahead and dealt with the substance of the lawsuit. The second factor was whether the individual mandate constituted a constitutional exercise of the Congress's Commerce Clause authority. The third topic was whether the individual mandate constituted a constitutional exercise of Congress's taxing power. And finally, whether the Act's Medicaid expansion was constitutional. So the law overall was upheld by a majority of the court. The individual mandate was found to be beyond the authority in the Commerce Clause, which is where virtually everybody thought that the authority for it lay, but within the authority of the taxing power. And the majority for that, as you may remember, was the conservative Chief Justice and the 4 more liberal members of the court. And then the court held that the Medicaid expansion was a valid exercise of governmental authority. Remember, the Medicaid expansion is really at the heart of the significant increase in the number of people covered. The coverage through employers that the individual mandate provides for, or through the exchanges that the individual mandate provides for, is substantial, but the big numbers of additional covered people come through the expansion of Medicaid. The Medicaid expansion was upheld as a proper function of the federal government under the Constitution, but not the mechanism to require any state that wanted any Medicaid funds at all to participate in the expansion. That was found to be an illegal imposition of federal power on the state governments because it was such a radical change in the program that already existed. And the majority for that holding on Medicaid was quite a different majority. The vote on that was 7-2 to both not allow it to be forced on the states, but allow it to go forward voluntarily, with a state-by-state decision on whether to participate. And there, it was actually a 7-2 vote, including all 4 liberal members, the Chief Justice, and 2 of the conservative members. So very different configuration and very different set of views than anybody expected. So with that background, I'm going to move to those 4 dimensions that I mentioned a minute ago. First of all, access. What the law does is it prohibits insurers from denying coverage or charging higher premiums as a result of pre-existing medical conditions. Right now, in most states, if you are pregnant and for the next 5 years, you will pay a 25% higher premium because pregnancy will then be a pre-existing condition. That sort of penalty. There's also something else. The next thing that's prohibited is just charging women more than men. Being a woman is actually treated like a pre-existing condition in most states. And, you know, it did pre-exist, I guess, before you applied for the insurance coverage. It's viewed as actually a part of society under the new law. The next access provision prohibits retroactively terminating coverage when people get sick. That's called rescission in insurance speak. And the way that works is, in practice, In other states, when you apply for insurance, you fill out a detailed health questionnaire. It is also very typical, and there are good actuarial reasons for this, in other states, to set an annual limit on how much an insurance policy will cover. It might be as little as $25,000 or $50,000, and or it might be $100,000 or $1 million, but an annual limit. And as you may know by now, 2 days in a hospital can run up to $25,000 if you were sufficiently sick or injured. So an insurance policy with a $100,000 annual limit is actually a short-term insurance policy. Similarly, under current law, the cumulative amount of benefits that you have received the whole time you've been insured can be limited, and that's very often $100,000 or $1 million. $1 million sounds like a lot of money. If you have something that requires a biotech drug, you can easily run through that in a couple of years. Again, those limits are prohibited under the law. Now, different effective dates apply to all these things I'm talking about, so this all gets gradually phased in until through 2014, but this is the result. I mentioned that the big access provision is the Medicaid expansion, but the health insurance exchanges are also a very important access provision in terms of giving people who don't get insurance through their employer, and that can mean a lot of people who are employed but who do not have either employers that offer insurance or who offer insurance at a price they can afford for their share of the premium. The exchanges are intended to standardize offerings so people can understand them, offer different premium levels for different levels of benefits, but to have a basic benefit package that is a reasonable, essential set of benefits. Second area the law deals with is quality. The law puts a much greater emphasis on prevention than has ever existed in healthcare coverage and regulation. Some people, have done that on their own. Some providers have pushed their patients to put more emphasis on prevention. One of the effects of the law that has gone into effect already, some of it last year, some of it on August 1st of this year, is no co-pays or deductibles for preventive care. It's amazing the extent to which people don't realize that the law has done that. I hear stories about people, going to the doctor and saying, well, I have a $25 or a $50 copay for this office visit, and the office staff says, well, actually, you don't have any copay because it was a preventive visit. And the patient says, gee, my insurance must have gotten better. And the office clerk says, yeah, I guess we've been hearing about a lot of insurance where that's happened. It's not the insurance, it's the Affordable Care Act. And there's a lot more emphasis on the law on outcomes and wellness. In the delivery area, that's the third area, healthcare now consumes about 18% of our gross domestic product in the United States. Now, as I said, I've been working in the healthcare arena for several decades. I remember when we were at 7% of our gross domestic product being spent on healthcare, and people saying that when we get to 11%, the entire economy is going to melt down. Well, we're at 18%. We're projected to go to 25 by 2020 without the things that happen in this law. And moreover, the things that are happening in experimental phases in other state laws, particularly, again, here in Massachusetts, which I'm not going to go into in detail, but we had a new law signed 2 weeks ago that attempts to hold the growth in healthcare expenses in Massachusetts over the next half dozen years to the same percentage as the growth in the overall state economy. So the way in which healthcare is delivered and how that drives cost is a monumental challenge because Yes, there's waste. Yes, there's some fraud. Yes, there's some malpractice costs. But a lot of what there is in the growth in healthcare costs is innovation. And sometimes people say, you know, since 1965, when Medicare started, the cost of healthcare in this country has, people use different numbers, let's say quintupled, and inflation has only been about 250 or 300%. And I say, look, I can give you a health insurance policy that's the same as the one you would have gotten in 1965 at 1965 prices. You won't cover antibiotics, and you won't cover most office visits, because those were mostly hospital policies in those days. And you only covered hospitals at a set rate of about $55 a day. So we can do all that. You won't like it at all, but we could do it. So trying to get a handle on that is what a lot of the goal of the law is, to not sacrifice the innovation, not sacrifice the advantages, not sacrifice the improvements, and still get a handle on all of that. One of the ways the Affordable Care Act tries to do that is the establishment of accountable care organizations, the infamous ACOs. What it's really trying to do in terms of delivery is get back to coordination of care, focusing ultimately on primary care. And there are a few of you who may be happy to hear that, and a few of you and many of you who may not. But the focus on a point of coordination within the healthcare delivery system really focuses on, yes, infrastructure, yes, incentives, but ultimately, who's the quarterback? And that's the primary care doctor. The law, in setting up this ACO structure, tries to reward quality on a set of benchmarks and cost efficiencies, none of which are spelled out in the law. Those are all to come later, but the concept is there. And it creates pilot projects to move healthcare from fee-for-service methodology to either bundled payments where payers pay for episodes of care, or global payments where payers pay for the care of a defined population. And finally, directly on cost, there's this myth that the Affordable Care Act raises overall federal spending on health care. It actually, as projected by the Congressional Budget Office in their nonpartisan analysis, reduces federal spending. Now, there are assumptions in there that may or may not play out, but it reduces federal spending. Yes, it reduces, for example, on Medicare, payments to insurers, hospitals, and drug companies, $716 billion, but it redirects that money to extend the solvency of Medicare from 2017 to 2024, and to close the donut hole on prescription drugs for Medicare recipients. The analysis, if we try to look at the model here in Massachusetts, and while it's not exactly the same thing, the Affordable Care Act is in many ways modeled by what we've done over the last 5 years here in Massachusetts. The incremental cost to the state has been 1% of the state budget, roughly $91 million. We enacted universal coverage here in 2006. This law we just enacted on cost containment is the third cost containment law we've done since then. Mass General just moved to being the #1 rated hospital in the country for quality in the midst of this environment. And we've been moving toward global payments, new strategies like tiered health insurance products so consumers can make a choice at the time of care, whether it's worth it to them to go to a more expensive institution. There's another thing called intelligent tiering, where they make these choices for particular procedures. Whole variety of strategies that I don't have time to discuss here.